Hello, I'm John DiBiase, and this is Welcome to Disabilities Journal. Today I have with me Kathy Bishop and Laura Robinson from up in Rochester. They join us via Zoom, and we'll be discussing the issues of aging with developmental disabilities. Not only developmental disabilities, but aging as a process which affects each of us. And so let's lead it off with Kathy and Laura. So, Laura, why don't you introduce yourself? Tell us a little bit about your background and your passion for people with disabilities who are aging.
Okay. So I'm Laura Robinson. I currently work as a program coordinator for the Geriatric Workforce Enhancement Program, a HRSA-funded grant at the University of Rochester in Rochester, New York. I've been in the field of intellectual and developmental disabilities for over 25 years. I began as a direct care staff. I did job coaching. I did skip. I taught skip, taught CPR, first aid, did orientation and training for new employees. I worked in several houses, supervised apartments. I opened houses, did policy and procedure, and eventually went back to school and got a master's in public health and did some research in health outcomes for older adults who are aging. And during my master's was when I met Kathy Bishop, who is one of my mentors and good friends. And from there, I have just continued to learn and be passionate about this population. I think even more so now because of the intersectionality of having a disability and being an older person, and noting that there are healthcare inequities and just basic inequities and discrimination against both of those populations in the world. And they need more advocacy, they need more services, and they need to be treated as equal across society. So I have a lot of passion around this topic. So that's a little bit about me.
Just real quick, for our viewers, explain what SKIP is.
SKIP, Strategies for Crisis Intervention and Prevention. This was the curriculum used to help staff help individuals with developmental disabilities who are having challenging behaviors, hopefully de-escalate the behaviors and figure out what the cause of the behavior was so that they would not harm themselves, others, or property. And it involved a lot of nonverbal interventions first, and then if things got out of control, then there were some hands-on physical interventions that could be done. And I believe it's still being taught in some places, though I don't believe it's being taught across the state.
Cool. Kathy, it's all yours now.
Thank you. And I have to say, SKIP was actually developed in what was then the Rome Developmental Disability Center in my department that I eventually retired from, staff development and training in the DDSO. I began actually in freshman in high school. In those days, I'm old enough and never know enough to retire. You went into teaching or nursing, and so I decided teaching was for me. At that point, was in Future Teachers of America, volunteered for a kindergarten class that had a little boy with Down syndrome. Absolutely loved him, fell in love with working with him, and spent my time. Well, within a week, I was called to the principal's office, wondering what I had done. The special ed teacher in those days, there was no such thing as mainstreaming. She was down the end of a long wing by herself, never got a break any time of the day. The kindergarten teacher told her, why don't you ask if she'll come and student teach and do teaching in your classroom? And I did. Every free period, every time I could, I was in teaching the class, to the point she would leave me to be able to take a lunch break, to be able to do break shift, to do preparation and things she couldn't do. And she became a lifelong friend and my mentor. So I was a preschool special ed teacher for about 10 years, was laid off from it with the state, and then was hired back as an ICF program manager, then hired into staff development, and I retired from in the state of New York as the Assistant Director of Staff Development, a very large DDSO, after 37 years there. And in that time, I also went to joined the University of Rochester, first as an advisor for the new training program in aging and developmental disabilities at the request of my director of the whole organization, who came to me and said, I'd like you to find out about aging and determine what we need to do. Fell in love with the topic and went back to school for my PhD. Many years later, I've worked for many organizations. I retired twice from the University of Rochester. Do a lot of I'm with the National Task Group on ID and dementia practices, where I do a lot of mentoring, consulting, and teaching on dementia-capable care practices. So this has been and continues to be a lifelong practice, and I hope not to have to retire.
You guys know that I had tried at one point to develop a campus for people with developmental disabilities who are aging. It actually was going to happen, except that Kathy Broderick retired, and there was a new commissioner, and a lot of things happened that just made it crash. The idea of caring for people with disabilities as they age is not new, and we always kind of knew it was on the horizon, but we've never dealt with it. Let's go with Laura first. What would you do differently than what we're doing today? And I think that's what I'd like to center us around, is doing what we would do differently than what we're doing today. Okay? Go ahead,
I think what would be different is for us to get away from the medical model as our primary model of teaching healthcare practitioners. The medical model subscribes that anything other than normal or typical is bad or pathological or not right, and wrong, basically. So anyone with a disability or any difference in functioning, difference in thinking is considered not good or not correct or not the right way to be, and so we must fix them. And so using the medical model as our standard of care is not a good way to be for people with people that just have natural differences in how they are. So moving more along to a social model of disability and understanding that disability is part of the human experience and that we are all at some point temporarily able-bodied. So TABS, T-A-B, is one of the words that's used. And we may at any point in our lives go in and out of having a disability, not having a disability, and understanding that we need to create environments where we can all be successful, regardless of what our functioning is at any given point in time. Mm-hmm. So if we start from that perspective, from that lens of just knowing that not everyone will be able-bodied their entire lives, how can we accommodate everyone throughout every stage of life, in every setting? So healthcare definitely subscribes to the medical model. But then if we look at housing, if we look at employment, if we look at all of the different areas where people are and where people do and where people have relationships and take care of activities, we need to make sure that all of these environments are accessible all the time for children through people of older age. And Kathy, I see you nodding, so I want to have you join in this discussion.
Just before Kathy joins, you both know I was very sick last spring.
Yes.
I was on my back in the hospital, unconscious for much of the time for 3 months. After 3 months, you can't use your legs. I was disabled for quite some time. So I woke up disabled. And that happens to a lot of people. Kathy, go ahead. You're nodding your head. Now,
well, let me respond to why that happened for you, but then I'll answer your first question. Anytime you are sedentary and you are not moving and continuing your muscle capacity, your joint and bone capacity, you are losing muscles and bones. They are the major receptors for allowing for mobility, for locating us in space, for being able to move from one place to another. 3 months means that you have lost you can in 1 and 2 days lose significant. You have lost so much that you're almost like an infant, where you need to redevelop that muscle and bone capacity so you have enough sensory information. I mean, that will come in, that will be sent to the brain, and hopefully all the medications and everything else, infection that was going on with you, wasn't interrupting the brain processing that information. And so that also you had to develop adaptations for. You literally became a person with a disability at that point, but with the capacity to redevelop again.
Yeah.
So I think this fits perfectly into your first question. I mean, actually, I think we have to really work on ageism in our society. You both know my husband had a triple bypass in November. We had to fight the medical community, the medical hospitals, the units. We even had to fight what had been our long-term cardiology care, because they've gone into the business model. It's only billing dollars, and they do judge who deserves to have surgery, to have the care based on chronological first, and then they go down who has insurance, who are people who have taken better care of themselves, are active seniors, but additionally they're understaffed. And they also do not think patients are part of the patient plan. This is the medical model we have right now. It's only because I've had a lifetime of advocacy that I knew to go to the CEO of the hospital and demand that my husband be moved after he sat for a week on just a drip, because we didn't know the surgeon was going to be suspended. This is how bad it was, and so we were moved to another hospital and received immediate surgery. We're the lucky ones. We're the ones that know how to do this. Laura's exactly right. You know, my passion is sensory processing, sensory issues, using the senses to modify the physical environment. I love the work I'm currently doing in dementia-capable care, because it makes me think of the whole way our system is structured, and we need to change the system. We need to stop thinking of it as system. We need to stop devaluing the caregivers and devaluing it whether they're paid or unpaid. We devalue what they do. There is, as much as we say we take care of them, we really don't. We could care less about them. And COVID has made it 100% worse. The other thing, we need to stop devaluing the people who have the expertise in the field, who have been working on this and now have some time to adjust their time to go on this advocacy. I've literally been told that I really should move out of the way and retire in some of my job positions. And, that is affecting greatly how we're providing care, especially for older people with disabilities. So we all need to become passionate together to take the disability out of the person, put it in the physical environment and the social environment, and we need to teach others how to do that and to respect those who do it and find ways. And we need to stop. About every 10 years, there's major turnover in the disability system, and everything changes. At the federal level, there's turnover every time there's turnover of powers. One of the reasons we had developed an amazing aging program, Laura with me, at the University of Rochester, known around the world for the work we did. And then after 12 years of funding that program, the federal government decided it was no longer a need or a focus, decided to go in another area. As soon as that happens, the universities, the medical centers and other centers don't see it a priority anymore. So we need to advocate at those levels for the funding and the awareness to come, and then to be looking at how we change the physical environments, the sensory environments to support the caregivers, as well as support people who are vulnerable and need assistance.
You know, you mentioned that big word, advocacy. Advocacy as professionals, to advocate to the government to fund programs, but also advocacy to teach parents and siblings to advocate for their loved one. I honestly, my daughter-in-law is a surgeon, and I'm not sure I'd be here if she wasn't involved in my care. Okay, so advocacy is a really important thing, and when you can't advocate for yourself, whether it's a mental issue, which I had, and which we develop in certain situations, or if it's a physical situation, they thought that I would never walk again. In fact, I had a physical therapist said, he's never going to walk again. Look at the way he can't even get up. And I said, oh, yeah. I won't say on the air what I said, really. But advocacy is a really important part of what we do, to teach it and to do it. You guys.
And I think that's part of the issue is expectations, historical expectations of people with disabilities, historical expectations of people who are older, and some of the stereotypes that have been embedded into our culture that prevent people from seeing the possibilities, seeing what could happen, from believing that, okay, this man wants to walk again. Why can't he walk again? Let's not give up immediately. Let's work with him and see what he can do. And we all need to change our attitudes and mindsets towards other people. Just because they're different or because they may not be able to do one thing or another doesn't mean that they wouldn't be able to one day, or they wouldn't be able to have a certain quality of life. All of this stigma, all of these stereotypes are kind of intertwined and bound together to create or to prevent people who are older with disabilities from having a good quality of life because of other people's expectations.
Mm-hmm.
I've been doing a lot of work these days with ECHOs. Actually, I've been doing a lot of work, have a 5-year and 4-year grant, complementary grants in the state of Texas. And it's to really develop it's telehealth. It's not telemedicine. It's telehealth to try to reach, especially the rural areas, for families with members with disabilities and the families themselves to be able to support. And it's through an ECHO, which is out of New Mexico, which is where you get the training to do the ECHOs. I also participate, and I know Laura comes on a lot. I think you participate one in Rochester area. It's absolutely wonderful because it has a hub team. It has spoke teams that come on and present case studies. There are two philosophies. One is all teach and all learn. And the second philosophy is that it's moving healthcare to the patient rather than the patient to the healthcare. I think we need to look at those models, but it's not that we're moving to healthcare. What we're really moving is the healthcare advocacy. We're teaching those people, providing the direct support, how they encourage a differential diagnosis, ruling out underlying conditions. That was what was not done well for you. They didn't really look to the underlying condition, assumed another condition, the condition that we assume of dementia. If anyone's pretty much over the age of 55 or 60, we start assuming, especially for people with Down syndrome, we assume any loss, any changes in the person are directly related to dementia. And healthcare providers, and also they're not encouraged by the advocates or the families, the caregivers, because they don't know to. And we need to learn to work in partnership with our healthcare providers to make sure a differential diagnosis is being done across the lifespan in every person, especially in older people, and especially with older people with developmental disabilities who may not be able to communicate what their symptoms are, or they're communicating in what we call a behavior. We need to stop labeling behaviors and understand they're a form of communication, and learn from what are the tips, the clues we're getting that help lead us to what we rule out, the underlying causes. In older people especially, we should always assume a multiple of causes. We should never assume, especially Alzheimer's disease, which should be the diagnosis of last resort, not the first one as it is. And so if we can learn to work in partnerships with our healthcare providers, and if our healthcare providers are willing to listen, which I learned a major lesson of what I never thought. My husband is alive because of me, just like you say you're alive because of your daughter.
And my wife, who just kept saying, save them.
Yeah. But it's even, you have
insurance
to be
is
able
paid
to
off.
give the information of what you want them to do to how to save. But not everyone has this voice, especially people that don't have good insurance. You can, when you have good insurance and you say save, them more likely to listen to you than if you don't. And let me say that Medicare is a great insurance if you also have a good supplemental insurance, which those of us who work for the state or universities or other have a good supplemental insurance. So we really need to learn how we work in partnership, and how we need to, at the medical school level, teach our healthcare providers how to work in partnership and how to listen, and to stop thinking that they're a business. We have to move it away from being a business, and how we're working together. We're not isolated.
Yeah. Yeah. I think that part of advocacy is teaching people to interview doctors, to choose not, you know, gee, tell me
If you
about
have
yourself.
the chance.
But to choose
Choice.
Yeah. But to
In
try to
rural
choose
areas,
a
there may not be a big choice.
Yeah.
Yeah, I'm in a
too.
small urban area. It was formerly a well-known hospital and service providers, and they've just collapsed. They've been bought out by a larger facility from out of state, and all they're looking at is billing dollars and who has the best likelihood of being able to survive and thrive. And for people with disabilities, it's especially someone who's frightened, who their form of communication is something irritating and inappropriate. No one's listened to them. They have maybe urinary tract infection, or it may be constipation, which are the most common reasons that people with dementia end up in the emergency room, who have actually even a good diagnosis of a type of dementia. It's the most common reason. The third is respiratory. And again, as we get older, we don't exhibit the symptoms. And if you never recognize them to be able to communicate them in the first place, you can't communicate them. And healthcare providers are not going to take the time or be able to take the time. We have to have a system of healthcare advocates who go in and work. When I retired from the state, actually it's been 15 years now. I think in the state you can retire early. I'm not quite as old as that sounds. The purpose I retired, I thought I was going to start developing a healthcare network for all older people in my geographical area. Have never been able to do that. I've been so blessed and fortunate to be able to do it at a national, international level with the work I'm doing with some of the national organizations and with. But that's what we need, and we need at the local level. Especially the huge doctors' offices, where they have multiple services and maybe have 40, 50 doctors and healthcare providers that are working for them. There should be a social worker, a healthcare advocate, someone who is the patient advocate that speaks for, that explains what's going on. And then make sure that the patient's voice and those who are the advocates are included in the patient care plan instead of left totally out of it. We were in 3 hospitals. Not one of the 3 hospitals, third hospital put us very much in the patient care plan, but the other 2 did not. It's unconscionable that this is the way we're providing expensive health care. And it could be much less expensive if the patient and the caregiver was involved and assumptions weren't made.
So there's a model now called the 4 M's. It comes from the IHI, the Institute for Healthcare Improvement, in collaboration with several other organizations. And they talk about the 4 M's, the things that should be asked for at healthcare appointments. So when there's not a lot of time, and this is just primary care, when you see an older patient, you should at least be asking about mentation, how a person's cognition is working, their mobility, their medications, and also there's another M that, of course, I'm forgetting right now. So mobility, medications, mentation, and what matters. Oh my gosh, how could I forget that one? That one is the most important. So here's where I think some of these things could be avoided. What matters to the patient the most? So in terms of what is the most important thing for you? So for you, John, at that point, it might have been learning how to walk again so that I can play with my grandkids, so that I can go out with my wife, so I can I can go and play golf. So what matters? So my dad is going through extensive chemotherapy right now for a very aggressive cancer. And sitting in the doctor's office with him on a couple visits, she never asked what matters in particular. She covered kind of, what are your medications? How are you moving? She didn't really go into mentation because he was answering all the questions, but she never really asked him, what matters to you? And so I inserted myself to say, well, what matters? Where do we want to be in the next week or in the next month? Or what's your goal? And his goal was to be pain-free from several of the things that he has going on. But if we can keep those 4 M's at the forefront of healthcare visits, I think that can help go a long way towards equity for older people as well as for people with disabilities. What I see happening in our state, and we're in New York State, is that we've gotten to a point where the governor is creating this master plan for aging. So there's some acknowledgement that we have more people who are getting older. There's also some acknowledgement that as people get older, more and more people have disabilities. But where do those two overlap and intersect? And what are we doing for that special population? So I'm hoping that within this master plan of aging that our governor is putting forth, that we've got some things that people can put into place in healthcare, but also in every other area of the community where you find older people. This is the largest growing portion of our population right now, is people who are getting older. We're not going away. We're all here. 1 in 5 people are over the age of 65. So what are we going to do when there are so many more older adults in our communities, in our society? We have to start taking care of them everywhere.
Laura, I've just been given we've got to cut this. I would love to have you guys back again and continue this conversation. It's been really good. And we've covered a lot of things that are important, not just to people with disabilities, but I think to the general population as well. People who don't have a disability, again, can become disabled at any time. Mm-hmm. And you don't wake up and say, I'm going to be disabled. I was holding my granddaughter. I said to Sheila, I don't feel well. I'm going up to bed. And the next morning I had 103 fever and was getting carried away to an ambulance and to a hospital I didn't want to go to. So anyway, I want to thank both of you very much for your time, for your energy. And Kathy, you got a lot of energy. We got, we're getting better. We're not just getting older. And Laura, I hope your dad has a positive outcome. And
thank you.
I want to thank both of you very much. We'll see you again soon.
Thank you, John, for having us.
Anytime.
Yes.
Have a good one.
Thank you, dear friend.
Bye-bye.
Thank you.
Please contact Governor Hochul and Commissioner Neefield, as well as your representatives in the New York State Assembly and Senate. Ask them to please include significant funding for direct support professionals who support people with developmental disabilities.